Tonight, Dr. Camille Carroll from Plymouth is going to talk about wearable technology and how it helps to deliver new Parkinson's services. Welcome, Camille.
So I'm going to give a bit of an overview of why we have changed our service at all, because of course for a lot of folk living with Parkinson's, their service might be meeting their needs. And this isn't to say that services do need to change, but in a lot of places the service might not be meeting people's needs. I don't think it was, or indeed still is, necessarily completely here in Plymouth. So that's a bit of scene setting to start with. Excuse me. And as you have probably heard, the number of people with Parkinson's is increasing globally, and it's thought that in the UK by 2025, which isn't so long away now, we'll have about 170,000 people living with Parkinson's. And just as a health service, of course, for everyone living with Parkinson's and their families and care partners and their friends, that's hugely impactful, but it's also impactful for us in health and care delivery. People who have Parkinson's have got a higher rate of being admitted to hospital, and they have a higher mortality in hospital and certainly longer length of stay when in hospital compared with people that don't have Parkinson's. And so for lots of many reasons, it's important that we try and improve the way that we deliver care. And I like this picture. This is from Sarah Regara, who lives with Parkinson's and has just written a thesis, a PhD thesis on personal science and her exploration of her Parkinson's. And I think this is a really powerful graphic illustration of where care sits as an organised healthcare service delivered care within the lives of people with Parkinson's. So if you're lucky, you might get an hour of neurological input per year. For some people, of course, it will be less than that. And all the other hours in the year, as people with Parkinson's, you're managing your condition yourselves, the same as any other long-term condition. And it's important that when providing healthcare services for people with Parkinson's, that we understand the context of the lives that we're trying to impact by our care. And a few years ago, I did a presentation based around what the treatment landscape was, future treatment landscape for Parkinson's was, and I thought that I would ask some people with Parkinson's what they thought treatment was for them, what their perspective was of treatment. And they said, importantly, of course, the consultation, but they wanted education about their Parkinson's, they wanted decision-making to be shared so that the decisions made about their care were personal to them. They wanted empowerment to become aware of Parkinson's, how it was affecting them, and skills and knowledge to be able to self-manage their Parkinson's with information based around lifestyle, diet, exercise, the support that's available locally. They wanted input from any discipline relevant to their care needs at that particular time. And they also wanted, and this was pre-COVID, they also wanted a choice as to how they were going to receive the care, whether it was clinics and face-to-face assessment or whether it was through a remote management. And not forgetting, when we're thinking about care, people don't live as islands. They live with care partners and other important people in their lives. And the role of the care partner is really important in Parkinson's. The care partner can be an independent source of information about how someone's Parkinson's is affecting them. The care partner can often be the person providing healthcare, helping make decisions, monitoring changes to therapy, reinforcing those lifestyle bits of advice and drivers of lifestyle change. They might often be responsible for managing the household finances, and if people are taking part in research, then often the care partner is a really important component of that, supporting the person to participate or indeed even being a participant themselves. So we did some work in Plymouth, and I'm sure this is just echoing what happens around the country. We did some work in Plymouth a few years ago now, looking to see what the national standard is for Parkinson's care, which is a review every 6 months by a specialist, be that a consultant or a nurse specialist, and then what we actually were delivering. And you can see that for about 60% of people that responded had not seen a nurse at all in the preceding year, and a significant chunk of people, however, were seeing consultants several times in the year, which may or may not be appropriate, but it does feel like a bit of a mismatch of where care is being delivered. And the other thing we found was that almost half of people were waiting more than 6 months before their expected see-by date for a consultant appointment. So what that means is if the consultant says that you'll be seen again in 6 months and you're waiting more than 6 months beyond the expected date, you've effectively waited more than a year. So that's quite a significant delay, and starts to say, well, maybe we aren't utilising the health resource that we have, the nurses in our various teams, hospital-based teams, community teams, and the consultant resource, which is of course more limited often, in the most strategic way to meet people's needs. And of course, this is all against a background of a prevalence of Parkinson's, which is increasing year on year. And of course, our healthcare services are not increasing year on year. So we're having to deliver more with the same number of staff members available. There is a national context for care delivery, which we need to be alert to as we're designing services. We need to, there's this concept of P4 medicine. So this is care which is predictive, preventive, participatory and personalised. And what this means is that for each individual person with any condition, we're trying to predict what's going to happen next. How can we prevent that? In what way can we facilitate the person with that condition participating in their own care decisions and their own care management, and making sure that is personalised to what they need, excuse me, as opposed to what we on the whole deliver, which is more of a reactive service, and it's certainly delivered often in a one-size-fits-all approach. The NHS long-term plan was published a couple of years ago, and this is, again, the same direction of travel, keeping people out of hospital, which is really important in Parkinson's, to keep people out of hospital if we can, that people are more in control of their care, it's personalised, they get it when they need it in the way that they would like to receive it. It should be digitally enabled wherever possible, and that's what we're going to talk about today, and hopefully avoid people having to come to clinics for face-to-face appointments, and by that we mean in person physically, as opposed to using a remote method, and ensuring that care partners are recognised and supported. So that sort of sets the scene. What I thought would be helpful is if I said what it is that I think would be a good outcome for an interaction with a patient. So what is it that we're trying to achieve when we interact with patients, whether that's in a consultation or a remote system of care delivery that I'll talk about. And these are in no particular order, but what I want to ensure is that someone with Parkinson's, that their symptom control is as good as it can be for both their motor or movement related symptoms and all the non-motor, non-movement related symptoms that are also affecting them. That if they need to be referred on to somebody else, whether it's another specialist like a urologist or a psychiatrist, that happens, that they're getting appropriate referrals to therapy, physiotherapy, occupational therapy, speech language therapy, that they and their care partner understand the symptoms that are affecting them, give them some strategies for how to identify, monitor and intervene for those symptoms, wrap that up with lifestyle advice if appropriate. And then I'm thinking, what are the likely future complications of symptom X or symptom Y, and what do we need to put in place to make sure that we reduce the chance of those complications occurring? So a simple thing, for example, would be if someone has got impaired balance, then it is highly likely at some point in the future that they will fall. And we know that if somebody falls, then there is a risk that they will break a bone. So we can prevent the fracture by supporting bone health. We can prevent the fall by putting in physiotherapy advice and other sorts of advice around keeping a safe home environment, those sorts of things. And I also want it to be clear how ongoing care is going to be delivered, so that people aren't wondering when that next healthcare contact is going to arrive. So what we did in Plymouth, probably about 4 years ago now, was appreciate that we were getting into a bit of a mess with not being able to meet people's needs. Our care pathways were not delivering good care. So we had the opportunity to run some workshops, and these were kindly sponsored by BL. I think we ran a series of 5 workshops over the course of a year and spoke to people across our referral footprint. So for us, that's people from Plymouth, people from West Devon, and also East Cornwall. So slightly different services in each of those 3 regions, and say, blank sheet of paper, what do you want from a Parkinson's service? And of course, we started that process by really evaluating what isn't working now. And what we heard was exactly what I've just shown you, that the waiting time between appointments can be really long. People don't feel they've got the knowledge to understand Parkinson's or how to manage it themselves. They want to be able to help themselves. They want to be able to see somebody when they need to, not just when the appointment letter lands. And also having clinics that are far away, physically far away, and obviously at pre-described times isn't necessarily that helpful. And out of those workshops came home-based care, which is a system of care that we have in place now, and we've been running for a couple of years. And this we designed with people with Parkinson's and their care partners, and it was a project sponsored by or funded by the Health Foundation, in association with the organisations that you can see at the bottom there. And what it is really is a care pathway that supports self-management, understanding that for pretty much every hour of the year, people with Parkinson's are living with it themselves and are not in a consultation. So whatever we do in that consultation has got to support people to manage their Parkinson's themselves. But if people are running into trouble, then they ought to be able to trigger a review, ask for a healthcare contact when they want one, and ideally with the most appropriate person. And in order to ensure a sort of a safety netting, so that we can identify if someone's running into trouble, even if they themselves might not have picked that up or might be reluctant to trigger a review, then we do remote monitoring in the background every 6 months. So really it's an iterative process that we hope that excuse me, is centred around the person with Parkinson's. We provide them with resources to inform people about Parkinson's, how it affects them, what people can do themselves, and then measures to check how they are in the background. And this is an ongoing cycle of information provision and feedback, which hopefully will result in those outcomes of an interaction that I explained we're looking for. So in home-based care, the way that it works is people are invited, or it's suggested that they might want to go onto this pathway of care. They're then invited to a training session, which when we started was a face-to-face group training session in a village hall or a room here on the science park. But of course then COVID hit, so we had to convert it into Zoom, and that actually works, or I think we're using a different platform now, but a video platform, and that actually works pretty well. For people who don't have access to that technology, we also are able to train people over the telephone, and we have now created a self-paced training that people can run through themselves. And what this looks like is a pack of resources that we send out to people, and in that pack is a book. You can see it there. It's called Parkinson's Disease, an Introductory Guide, which is produced by the Canadian Parkinson's Association, and is a step-by-step guide through Parkinson's, the symptoms, how people can help themselves, the sorts of drugs that are used to treat Parkinson's, and other useful bits of information. We then have a resource book. It looks slightly different from these now in this picture, explaining how home-based care works, what people can expect, and how to contact if they're running into difficulty. And then we've also produced a series of tracking cards. I'll show you those more in a minute, which come in a box like a playing card deck. And of course the wearable, we use the Global Kinetic PKG device. So as I said, it's got these 4 main aspects to it: the trainings, that people understand how their care is going to be delivered, the resources, triggered contacts, and then the remote monitoring. So the tracking cards So I'm just going to scroll towards the next one because I wasn't sure. Okay, so the tracking cards are split into 3 different colours. One colour for non-motor symptoms, one colour for motor or movement-related symptoms, and another one for activities. And on each of these cards, so here's a non-motor symptom of feeling faint or lightheaded. On the reverse of the card, it explains what that is. So what people can experience. So it's feeling explaining that it's caused by a drop in blood pressure, and that as well as feeling faint or lightheaded, people might have headache or confusion or shoulder pain, or worst case scenario, blacking out. Why does this happen in Parkinson's, and where people can go to find information on how to manage that themselves, or a bit more information about it. So this particular example, there's more information on page 81 of the Parkinson's guide that I showed you, and this link here takes people through to the relevant bit of the Parkinson's UK website. So it's the information that Parkinson's UK provide. This particular symptom has got a red triangle, and there are a few symptoms in this bracket where there's a red triangle. So obviously feeling faint or lightheaded, as I've mentioned, it can lead to falls or blacking out, which is quite a significant occurrence. So if this is new for somebody, excuse me, or if it's getting worse, then we need to know about it. This isn't something that we want people sitting on. We would like this flagged sooner rather than later. Not everybody thinks in terms of symptoms, of course. Some people think in terms of activities. So we have a set of activity cards, and I have to say all of these cards were written by people with Parkinson's and their care partners. So this particular activity, people might notice that they don't enjoy food like they used to. And then on the back of that card, it goes through a bit about why that might be the case. Maybe it's to do with swallowing difficulty, or maybe it's to do with constipation, or maybe it's to do with lack of taste or smell. Maybe it's a problem that just the physical process of eating, difficulty getting food to the mouth, or feeling sick after eating. So people are then guided to the relevant symptom card, which will then give them the information which I explained before. The remote monitoring, the crux of it really is the PKG device, which, and those of you who've worn it will understand it's quite a chunky piece of kit, and the strap isn't exactly the easiest to do up. It's the company are continuing to iterate it, so hopefully it will become easier to put on, and I can't remember if the next one's a bit smaller, I forget. But it's now, at least it looks like a watch and not a grey box, which the previous one did. So people wear this. It's essentially an accelerometer, so it's like a Fitbit. Probably less sophisticated actually than a Fitbit, that you're just wearing on your wrist, and it measures movement in 3-dimensional space. And with that, of course, that I'll show you in a minute, that gives the team information about movement. What it doesn't explain is anything that might be impacting that movement. So in home-based care, I'm interested to know, we're interested to know, how do these movement changes that we're perceiving, how do they actually reflect what you're able to do in daily life? So we send out questionnaires with the device. In this case, this is the Unified Parkinson's Disease Rating Scale Part 2. And for those of you who've had it, you'll understand this is a scale which looks at motor activities of daily living. So are you able to undertake self-care, hygiene tasks, eating? How much does your tremor impact on your daily activities? What's your mobility like? Are you able to walk independently or turn over in bed independently? So this gives me just a context in which to set the information that I'm getting back from the watch. I also want to know what else is going on, particularly around the non-motor symptom burden that people experience, which, as you'll know, can be quite significant, and any problems with mood, which is what this addresses. Is a hospital anxiety and depression scale, and this is a sleep questionnaire. So if I see that someone's sleep is disrupted, for example, using the PKG device, I can see that does not look like they've kept still overnight. It looks like there was quite a bit of movement or periods of non-sleep. I don't know what to say about that unless I got a bit more information about the sleep, and that's what this scale gives me. It explains to me whether people are uncomfortable overnight, or whether their sleep is disturbed by needing to get up to empty the bladder, or might be disturbed by vivid dreams, or there might be nothing particularly disturbing the sleep, they're just wakeful through the night, and I would treat each of those things differently. So the questionnaires actually give a richness of information which allow me to set the wearable data into the context of the person who's worn the wearable and how Parkinson's is impacting on them. And then, very important, related to that are these questionnaires, the quality of life questionnaires. So with the device, we send out the PDQ-8, a Parkinson's disease quality of life measure, which is short. It's only 8 questions, as its name suggests. And that allows me to see how much is everything that I now know impacting on your quality of life. Because if it isn't impacting at all, then we can sort of agree that we'll take if it ain't broke, don't fix it sort of approach. But if I can see that actually you are quite impacted in that domain, then maybe we do need to intervene. The PDQ-39 is like the PDQ-8, but much more detailed and much more robust. So it is likely that as we iterate this, we might drop one or either of these questionnaires, so we're not repeating the information. But at the moment, because the PDQ-39 is more detailed and more robust, I find it reassuring to see that what I'm seeing in the PDQ-8 is mirrored in the PDQ-39, and we do that at a different time point as well. So it gives me an idea of how things are evolving over the course of the year. And we also send out the PDQ-C. The PDQ-C is Parkinson's disease quality of life from the perspective of the care partner. And the care partner voice here is really important, and it's very important that care partners, as I mentioned in the long-term plan aspiration, are supported and recognised for the impact that being a care partner can have on their lives, but also the life of the person with Parkinson's. We created, again, with people with Parkinson's, a patient-facing report, and the idea of that is to support people in being able to self-manage their symptoms in between reviews. So when we first started using the PKG, we evaluated this against 2018, so 4 years ago now. We evaluated this again with patients. We designed a questionnaire to understand whether people were finding it helpful or not helpful, and we sent it to the first to 100 people who'd recently had a PKG. We got 61 responses back, and we asked people around questions about how they felt receiving it, using it, how the results were communicated, whether they felt it impacted on care, and their overall satisfaction and areas of concern. And so I'm just going to show you a couple of outcomes from that. And this is, the question was, how valuable was the PKG in providing data to your doctor or nurse about symptoms that you could not have provided, i.e. what is it picking up that you yourself was unaware of, or wouldn't have said was related to your Parkinson's. And you can see that the overwhelming majority of people thought that this was valuable to a greater or lesser extent, and only a few people thought it wasn't valuable. The majority of people, again 61%, understood that as a result of what had happened, what had been seen on the PKG device, recommendations were made as to changes in treatment, and for most of those people, those changes were implemented. And the vast majority of people were happy that they did not have to travel to clinic in order to have this information extracted, if you like, to be that information to be available to the healthcare team. So this is how we use it in home-based care. For those of you who haven't seen, what we get back is a graph, essentially, with different coloured lines on it. So the red lines here are when the tablets were due, and when you have the device, it is pre-programmed with those medication times. Somebody from the company phones to say, you're going to receive your PKG this week, can I just confirm your tablet times with you? And then the thing vibrates on your wrist when the tablet is due, and then when you take it, you put a swiping action, and that acknowledges that you've taken the tablet. And that's what these diamonds are down here. Those acknowledge that's when the tablet was taken. You can see this is a day. This starts at 0600 and goes through to 2200. The ones that we have in our service also cover the overnight period, so we're getting 24 hours. And then what we have is slowness of movement, which is the blue line, and excessive movement, which is the green line. So slowness of movement is what we would call bradykinesia, and excessive wriggly movements is dyskinesia. And the algorithms on the device can differentiate this from tremor. So tremor is, on the whole, mostly can differentiate from tremor. So tremor is a rhythmic, repetitive movement at a particular frequency and a consistent amplitude, whereas dyskinesia is more disorganized than that. So on the whole, it differentiates well enough from tremor. There is a lot of other signal gets through into this dyskinesia curve. So if somebody was, playing tennis or going for a run, that might show as a peak on the dyskinesia curve. It looks slightly different, but that isn't as well defined, I don't think, as the bradykinesia metric. So you can see in this particular example, and I should say the lower the curve here for the bradykinesia, the slower one is, and the higher the curve, the quicker one is. And you can hopefully see these two thicker grey lines going across the middle here. This is where 50% of people without Parkinson's would spend their movement day, in between these two lines. And you can see on this example that this person is taking a medication at 0700, and it works within about an hour. They're okay for about 2 hours, and then it's wearing off before the next dose is due, which also takes an hour to kick in, and that's the pattern through the day. So that's the way the PKG works. And then there's another plot for tremor and another plot for immobility, which correlates with sleep. I'm just going to pause because I can see a question in the Q&A. So how many other healthcare trusts are offering the pathway? I think there's about 20, 25 trusts possibly using the PKG, and we all use it slightly differently. So for this particular pathway, I think we're the only ones using it. As you'll appreciate from what I explained about the questionnaires, it's pretty burdensome, and I'll come on to some of that in a minute. So we have now got funding from NHSX to digitize elements of it, which will make it less burdensome. So this is burdensome for people with Parkinson's and for their care partners, helping them fill out the questionnaires. It's burdensome in the organisations, because people have to scan them in, enter all the data, analyse the data. We're moving numbers from box A to box B. So all of that is administratively burdensome. So this isn't, as it is, it's difficult to scale and spread. So with our current funding, what we're hoping to do is to streamline this so that it is much more easily adopted by other services. So this is the report that people with Parkinson's receive. It is slightly more wordy, actually, I have to say now. I write little essays in these boxes. So for example, I wouldn't just say here, but basically it's divided into several columns. So the symptom of interest is the first column. We've included a patient score column, so that people want to rate something themselves and track it themselves over time. They can put that in. That's for their information. That doesn't come back to us. And then there are essentially three outcomes here: no action required, keep under review, or action required. So it's very clear where people need to do an action, and then the action is then specified or clarified in the last column. And so I wouldn't write now self-management. What I put, if someone is having difficulty with overnight sleep, I'd say, it looks like you're having difficulty with overnight sleep, or thanks for letting me know that's the case. It seems to be related to whatever, overnight discomfort. It might be that tweaking your medication in this way or that way might help. There's information about this here, or you can look at more information there. Some things I will say, looks like you've got a problem with bladder and I want to know more about that. So I use the opportunity then to send people a more detailed bladder questionnaire, so I can then understand how impactful the bladder symptoms are and whether we need to refer to urology or tweak existing bladder medication. So this is a sort of the first step of further interaction to really nail down people's symptoms and make sure that we're getting to the bottom of them. I'm going to share with you some quotes. So we undertook an evaluation of the pathway a couple of years ago, or within the last 18 months, and part of that was a qualitative piece of work which we commissioned from a qualitative researcher. And what she did is speak to people on the pathway and their care partners and understand the benefits, but also some of the pitfalls. As we've developed the pathway, it is co-led with people with Parkinson's, and so we're always iterating it and working out what doesn't work, where the challenges are and what we need to change to get it to work better. So in terms of being acceptable to people, on the whole, people did find that it was acceptable. They could find it was empowering the information, using the technology in a way that was sustainable. The resources, we put a lot of work into writing the resources. They were readable, very accessible. We designed the resources, I should say, with healthcare engineers from University of Sheffield Hallam University, and we put a lot of effort into the look and the feel and the colours and the way it's packaged, that it is accessible and hopefully looks engaging and inviting, or be something that people do want to interact with. And people did value that, that the resource pack was helpful, and that a lot of information that was useful could come out of wearing the watch. Some people, of course, had a different view. So the watch was big, it's uncomfortable. Some people do find it stigmatizing. It can be difficult to swipe. That continues to be the case. The questionnaires are burdensome. For some people, they are stressful, and it's very different answering a question in a questionnaire than being asked the exact same question in a clinic. And that, that's suitable for some patients. It doesn't suit everybody, and some people wanted to have a sort of more routine relationship with their doctor, and that's fine. It's important that we understand and incorporate that. The care partners also felt that there was a lot of useful information, and for the care partners particularly, for them to be reassured that what was happening to their loved one was understood and part of Parkinson's, rather than not understanding what was going on. For some, they felt there was too much information, and of course the questionnaires are burdensome, and for some people the burden of filling out those questionnaires landed with the care partner, so we have learnt from that. Overall, people found it effective, that they felt that they were getting more timely intervention for symptoms, they felt more empowered to manage the symptoms themselves, that they could have peace of mind through the contacts. So we have had triggered contacts on the whole. We can see people within 10 working days, and they felt that the whole package has helped people understand their Parkinson's more. And the same for the care partners, that they felt, again, empowered, that it works quite well, and for some people it was really quite impactful to have this as a resource and support that they could turn to. However, it's not without challenges, and for people that are on the care pathway, they will know that a significant challenge is the resource that we've talked about, the administrative burden, for want of a better word. So we have had to create a whole new system for managing patient flow through the pathway. The hospital is set up to manage outpatients. It's not set up to do remote reviews and to have triggered reviews, or at least within the Parkinson service. So we've had to create that. We've had to create whole new processes and systems for managing data. The workforce that delivers the pathway has had to learn new skills. We're looking at data and making decisions, clinical decisions based on data, in a way that we're not used to doing. The support staff have also had to learn data management skills, IT skills. We're dealing with web portals, Excel spreadsheets. So there's a skill gap within the workforce, and that the administrative workload has meant, of course, that we have that there are now pinch points, and one of the critical pinch points is reporting the PKG. So I know that there is now a few month delay in reporting the PKG, so we're not reporting back in the timely way that we were at the start, and certainly what we want to get back to again. And the other challenge for people with Parkinson's, particularly those whom are used to a traditional care delivery model where they might have seen the consultant every 6 months and been given advice and weren't really maybe engaging in self-care in between times. This is a new way of thinking about living with Parkinson's and supporting people to become actively engaged in self-care. And for some people, they take to that very easily, and for other people they need more support, particularly around embedding lifestyle changes, for example. So that there are challenges. This is still a work in progress. As I've mentioned, we have some funding hopefully to address some of those challenges. And I think that was all I wanted to say. So I hope that's been helpful. I'm very happy to take any questions.
We'd like to thank Dr. Carroll for giving up her time to speak to us this evening. The question and answer session that followed her talk is in a separate video available on the website.